Okay, so let me see. We are actually going to do muscle relaxants and opioids in the same breath. So as far as muscle relaxants are concerned, we have central and direct acting. So that makes a difference because our centrally acting baclofen inhibits reflexes at the spinal level. Um, and so that causes wide span muscle relaxant, kind of a CNS depressant. Typically, you can't do much in the day if you take your baclofen because it makes you groggy, tired. And for most of us, if we take something like this, it's just going to make us go to sleep right away. Dantrolene is an interesting medication, muscle relaxant, because it's direct acting. So it directly prevents muscle contractions. Okay, directly prevents muscle contractions. So it does not affect the cardiac and the smooth muscle though. Okay, so you have less of a systemic effect when you take dantrolene. So for certain situations, it is a preferable medication, but not all. So some nursing considerations for muscle relaxants is you want to check their baseline level of consciousness because they can become drowsy and sleepy, and maybe they're drowsy and sleepy before they take it because of the pain or discomfort that they're in. So if that's the case, then finding out an hour or two later after taking the medication that they're drowsy is not a change in status. It's the same. We just want to, but if they are alert and oriented, no problem, awake, watching TV on their phone, and then 2 hours later, it's hard to wake them up, then they have a definite change in level of consciousness, and maybe some interventions need to be taken. So like I said, they'll be weak, drowsy. They can get urinary retention because it decreases the muscle contractility, so they might have a difficult time urinating. Um, that would be a call to the physician because that could be potentially a problem causing hydronephrosis. They could become constipated, right? Because maybe their peristalsis isn't working as well. So let's give them, make sure that there is some stool softeners on the MAR, and you're monitoring their stool counts to make sure that they're not becoming constipated. Hypotension, if it's a CNS depressant, then you're going to have hypotension. You also want to watch that for bradycardia as well. Basically, with these meds, you're going to do all of your checks that you would for opioids, which is check their baseline vital signs, their heart rate, their blood pressure, their respiratory rate, and their GI status as far as peristalsis is concerned. Monitor for confusion and check their liver labs prior to administration. Lots of prior tos. Because of the hypotension, you want to make sure to educate the patient to change positions slowly. Because of the constipation, we're going to increase their fiber and fluid intake, whether that be in the hospital or educating them for when they go home. They need to report severe constipation so that we can correct prior to it becoming a small bowel obstruction. They should not be, if they're taking these constantly over a long period of time, then they shouldn't stop abruptly because it can cause seizures. That will be the same for opioids and benzodiazepines as well. And that's not if you're just using them every once in a while, that's if you're using them consistently on a daily basis. They should not be taking alcohol, antihistamines, or additional CNS depressants because that will actually increase the side effects that these medications will have. It will exacerbate it. So it would exacerbate the hypotension, the confusion, the weakness, drowsiness, um, bradycardia, and respiratory depression. All right, let's talk about opioids. So I want you to think of the mu receptors. Okay. Um, the mu receptors are what the opioid attaches to, and this is the response that happens when the mu receptors are activated by the opioids. It causes an analgesic effect, a respiratory depression, a sedation, euphoria, physical dependence, and GI motility. These are all the things that we need to look for when giving these medications. So analgesic, yes, it's going to take away the pain, hopefully. Respiratory depression, okay, this is part of the mu receptor. So we look for respiratory rate prior to administration. Um, Sedation causes drowsiness, but with that kind of comes a CNS depressant kind of a feel where also you become hypotensive and bradycardia. That's why when we do these medications, we check the vital signs, not just the respiratory rate. Euphoria, physical dependence. These receptors like the opioids and the effect that it gives, and so it tells us that we want more. And it decreases the GI motility, which causes constipation. There's actually a diagnosis now for opioid-induced constipation. So we need to monitor for constipation. We need to monitor their GI tract and the peristalsis, make sure we're having bowel sounds. Give a stool softener with the opioids, or just give them once a day. So make sure that that is on your MAR for your patient. And when we're listening to the GI motility, if there are sections that have no sound in 5 minutes or it's slowing, you're noticing that the GI motility is slowing a little bit, then you need to call the doctor, because there's actually things that we can give to increase that motility, because we might still need to give them the opioids, but maybe we need to increase the medication to increase motility, or maybe we need to give them some more stool softeners. Okay, it can cause something called a paralytic ileus, which is a section of your GI tract that stops movement. So here are some narcotics. We have morphine, hydrocodone. Hydrocodone, as you can see, there's a split here, and that's because it's 5 milligrams. This means it's 5 milligrams of codeine and 325 milligrams of Tylenol. So if someone, I was talking about Tylenol IV for pain medication after orthopedic surgery. So this in itself would put them over the limit. So we could just give them 15, like morphine or codeine that doesn't have this mix. However, this mix of this Norco mix, codeine and acetaminophen, does work very well. We have oxycodone, which is typically 5 to 10 milligrams. I'm not going to test you on the dosages. Dilaudid, we give 1 to 2 milligrams IV push, or we can give 4 to 8 milligrams PO. Codeine is PO. Fentanyl is in micrograms, and we give it as a patch. So with fentanyl, you're going to be changing that patch. When you do change the patch, use gloves, because it's absorbed through the skin, and so if you touch this fentanyl patch, you can get some fentanyl in your system, and most of us are not used to fentanyl, nor have ever taken fentanyl for anything, and so this could actually drastically decrease your blood pressure, and you could, and your heart rate and everything, and you could fall down because you would get orthostatic hypotension. So be careful with that, and not just fentanyl patches, also nicotine patches as well, okay? And then we do use methadone, so we all think of methadone as like a methadone clinic for people so that they don't have to take their, illegal methamphetamines and so on. But we can give this for pain. It is given for pain. The doctor has to have a special certification to prescribe methadone. So sometimes it takes a little while, but we do use it. So let's look at these pictures for a moment. This is morphine for an IV push. This is a vial, or a cylinder, sorry, of morphine 2 milligrams per ml. This is a cylinder for morphine 4 milligrams per ml. There's very little difference in the packaging. Here there's a slight blue, and here white, maybe a pinkish color. But you could see how easily those could be mixed up. So this just enhances the fact that we need to read the label, read the dosage. Look at how much dosage is per milliliter and make sure that we're giving the right dose. Just this vial and this vial, this here is twice as strong as this. So you don't want to give a little old lady 4 milligrams when she should really be only be getting maybe 1 or 2 milligrams, okay? Down here for this picture, this is again the morphine 4 milligrams. This cylinder here is actually dilaudid. Dilaudid down here, as you can see, is 5 to 7 times stronger than morphine. 5 to 7 times stronger. I really want you to take that into consideration and into heart and really think about that. Because you pick up this vial of Dilaudid and you give it instead of this morphine 2 milligrams, and you've got a really big problem on your hands. Okay, this could technically completely depress someone's respiratory system and stop them from breathing. Okay, so none of this should be taken lightly. These cylinders as well, what I'd like to tell you is normally we put air into a cylinder for the pressure inside into a vial, right? We put like a milliliter of air in, and then we pull out the milliliter of drug. That is not the case with these cylinders. You do not push air in. If you do, there's a little cap right here that will just pop right off, and then all of your medication will come scooting out the end. Okay, so no air in cylinders. Tablets are great. The tablets for Norco, oxycodone, all of that, morphine are good because they might take a little bit longer to get into your system and to work, but they last much longer. They have a much longer effect on someone's pain. The IV push will act, within the first 15 minutes probably, but it also dissipates really fast. Okay, so that's a good educational point for patients because rather than getting this every 2 hours, remember that World Health Organization pain scale we were looking at, it really is best for them to have an underlying tablet to keep the pain at bay, and then use the IV push for what we call breakthrough pain. So maybe this will keep their pain under control for a period of time, and then they might only have to have the IV every once in a while. Okay, and that's much better for their system as well. So as far as contraindications, paralytic ileus, they might have one already. We don't want to make it worse. Respiratory depression, if they have respiratory depression already, COPD, their ventilation perfusion is not appropriate, we really need to watch for respiratory depression if we're given these medications, and possibly, hopefully, give a lower dose. Bronchial asthma, we don't need the bronchioles to be depressed at all because that will just inhibit our coughing. Like codeine, for example, is also an antitussive, which is an anti-cough, and we don't want that when we have bronchial asthma because that's going to make our asthma worse. There are some biggies as far as drug and food interactions. So MAOI inhibitors that you will see in psych are a major contraindication for opioids, as well as additional CNS depressants. And then there's also a St. John's wort that is, I guess, a very common over-the-counter remedy that people use, and it is not appropriate for when you are taking opioids. So this is just a sum up of other considerations. We monitor. Respiratory rate, heart rate, level of consciousness, and sedation. And we don't just monitor prior to giving these medications. We monitor if it's an IV push, we go and reassess 15 to 30 minutes to make sure the patient is safe, to check on their pain levels. And then for a PO, we can go anywhere from 30 minutes to an hour to preferably an hour to, again, reassess and check these, the vital signs, okay? It is a very good and prudent thing to actually take their patient's vital signs, either 30 minutes or an hour after you've administered these medications to make sure that they're safe. Again, assess for constipation, request a stool softener. If they're going home, avoid alcohol. They are not allowed to drive or use heavy equipment, as we always see, because it can affect their level of consciousness, sedation, drowsiness, and so on. And then assess the patients for their over-the-counter medications by doing a med reconciliation of their home meds. So to counteract the effects of opioids, if someone does have an opioid overdose, then we have Narcan. Narcan competitively blocks the effects of opioids, and so what it does is it literally just kind of blocks that receptor so that the opioids cannot attach to it. So it's good and it's bad. It's good because we don't want any of those effects, that respiratory depression, hypotension, all of that. And so that is good because by blocking it, we stop them from dying. But the bad thing, unfortunately, for the patient is that now, if they actually were in pain and it wasn't just a, let's say it was an accidental overdose and they were in actual pain, then now all of a sudden, immediately their pain is back. So they go from 0 out of 10 because they've had an overdose to a 10 out of 10 plus. Okay, there's no middle ground. There's no easing into the pain and having some endorphins working because you're just blocking the pain from the opioids. So if with no endorphins in your system, so to speak, I know that's a vague comment, but now all of a sudden you're in no pain to extreme pain. So you're going to have hypertension. You're going to have tremors and anxiety, ventricular arrhythmias. So this is actually saving their life, but it is causing a lot of problems until we get them under control. So because of these, we need to monitor their vital signs consistently, EKG changes. We need to stay with the patient. We need to monitor their level of consciousness. We need to know the peak time of the original narcotic that the patient had. Because if the peak time is 4 hours, let's say, then we need to monitor this patient frequently for 4 hours because they might have, the Narcan that we give them might wear off before the peak time of the medication. So we might need to give them another dose. Okay, remember in class I was saying that we had a patient that his friends came in and gave him heroin through his IV in the hospital, and they gave him so much that he had to go to the ICU because regular Narcan was not working very well, or he'd go back into a slumber, and so they had to actually put him on a Narcan drip, which is pretty extreme. Now what we can get as well, which is great for home use, if you do have a patient taking a lot, or a family member taking a lot of narcotics at home, or maybe even a drug user at home, is this nasal spray. So Narcan now comes in a handy nasal spray, which is great. It's much easier to use, especially if you're not in the hospital setting. Now, lastly, our adjunct medications, and we talked about these at the beginning of one of the pain modules. So we can use antidepressants for that serotonin effect. We can use local anesthetics, which blocks peripheral nerves. That could be subcutaneous, or it could be a patch. We use lidocaine patches a lot. Corticosteroid injections, this is typically straight into the joint that is inflamed. It's painful to get, but it directly stops the inflammation, which helps with the pain. And then lastly, we have gabapentin, which is actually an anticonvulsant, so it's an anti-seizure medication, but over time had been noticed that it helps with neuropathic pain, so nerve pain. And so now its primary use is actually for neuropathic pain. So there's gabapentin, and then there's pre-GABA. It just comes in an oral dose. It very few side effects and works very well for diabetic neuropathy, or medication, or disease-associated neuropathic pain, and even fibromyalgia. Thanks for listening. Hope this was helpful.